It's our pleasure to have you in our second webinar about cardiology, sponsored by Asino. We have today our distinguished speaker, Dr. Rania Swais, and we have Professor Hassan Al-Farhan, our moderator for today's session. So, Professor Hassan, the floor is yours.
Thank you, Dr. Ali. Hi, everyone. It's a very nice time to be meet in the second scientific session held with the collaboration with the Asino company, with the Iraqi Scientific Council of Cardiology, in collaboration with the American Heart Association. And this is the second teaching program. We are talking about very interesting subject, and I would like to inform you that we have changed in the speaker. The first speaker, Prof. Dan, he has some urgent situation, and very grateful Dr. Rania Swais, with very short notice, he take over, and she will be our speaker today. I'm very great privilege for me, and it's a pleasure to introduce our speaker today. Dr. Ali, please. Dr. Rania Swais, it's Associated Professor of Medicine, Division of Cardiology, Northwestern University, from School of Medicine Interventional Cardiologist in Chicago. Dr. Swais received her medical degree from Duke University School of the Medicine, and she had a postgraduate training include internal medicine and cardiology, and currently she is well-known interventional cardiology, and we are very glad to have Dr. Rania Swais with in our meeting today, and she will talk for a very interesting subject today. I'm ask our audience if shared any question or interactive session, they can type their question in the a question and answer part. And we have two presentation, the first presentation, and then we will talk, we will have the interactive session and the question and answer and discussion about the first presentation, and then we go to the second presentation. Dr. Rania, if you are ready, Professor Rania, the floor is yours. Please go ahead.
Excellent. Thank you very much for having me. It's a privilege to speak to you about some of the interventional cardiology topics that we'll be discussing today. And I say good evening to you from Chicago. And as Professor Hassan said, you can put questions in the Q&A, and we'll happy to discuss them. It'll be even more interesting if it's a nice conversation and discussion. The main objectives for today's conversation is to talk about main indications and results of revascularization, and also more specifically focus on instrumental procedures, both to treat acute and chronic coronary syndromes. And we're primarily going to be covering two papers today, and that's how we're going to break the subject into two sessions. The first paper will be reviewing management of percutaneous coronary intervention complications. This is based on a paper that written by Dole and his colleagues that was published in 2020 that rose out of these algorithms from these two conferences. So complications of percutaneous coronary intervention, PCI, may have significant impact on patient survival and also on healthcare costs. PCI procedural complexity and patient risks are increasing as we do more complex procedures and offer patients more options, and operators must be prepared to recognize this and to treat the complications. Examples include perforations, dissections, hemodynamic collapse, no reflow, or entrapped equipment. Unfortunately, there are few resources to train the operators on complication management, and there's often uncertainty regarding the correct management that may result in undertreatment of patients that have high complexity coronary disease because of the fear of specific complications. So in light of the need to treat these complex patients, it's important to address how to manage complications in order to be more confident in the treatment of these patients. The authors of this paper basically coordinated the learning from complications conferences that they had, how to be a better interventionalist. And the goal was to disseminate the experience of high volume operators that have extensive experience, especially in chronic total occlusion and high risk PCI because of the advanced techniques required. The conferences were in 2018 and 2019. And through these meetings, algorithms for treatment of patients to recognize complications early, to treat them effectively, and then also to include a team-based approach to care of these patient complications. And these conferences basically address these issues, and then the result is this paper. The thought is that if you think of a problem in advance and you have an algorithm to approach the complication or the problem, and it's well thought out and addressed beforehand, it'll be easier, it'll be more logical and systematic to respond to these life-threatening complications. If we've never thought through them and never sort of thought in our heads or in the algorithm what we're going to do next, it will be difficult to respond to these complications. So the general principles in complication management, basically, the first thing that you do when you are suspecting a complication during procedure, the first critical decision is whether you need to act immediately or if you can pause to evaluate what's going on with the patient. These authors propose that using a 60-second rule, so you taking 60 seconds to assess whether the patient or what's happening with the patient, consider the differential diagnosis and formulate a plan, might give a better option to make sure that all the problems are addressed rather than automatically focusing on one problem and trying to address that and missing other things that may also be obvious. If the answer is yes, and taking 60 seconds is possible to assess the patient, then that involves communicating the suspected complication with the staff. So talking to the staff and the team and saying, we think that this is a dissection or a perforation, for example. Confirming the diagnosis or evaluating for alternatives. Using, if we're concerned about a perforation or tamponade, then we can confirm the diagnosis quickly with an ultrasound probe on the chest. And if that's confirmed, then number 3 is consider multiple treatment options. And then 4, of course, call for assistance from other colleagues as appropriate, if that's, calling for surgeons, or sometimes these complications just require another interventional cardiologist to work together. And so that would give you the chance to do that. So it's more likely to be successful in treating this patient if these 60 seconds are taken to assess the situation and follow these steps, than if someone just jumps through into the treatment and may miss some other obvious findings that the patient may be exhibiting. The first important thing to consider when doing high-risk procedures or CTO procedures is to have equipment available for managing complications. And they hypothesize that there are certain types of equipment that need to be in the cart, others that need to be in the room with the patient, and other that need to be in the hospital, but not necessarily in the room, so people that you could call, for example. So in the cart, the suggestion is to have a pericardiocentesis tray. In the event of tamponade, that needs to be readily available to drain the effusion from around the heart. Covered stents, if available. Consider coils or microcatheters for delivery of the coils, or at least know what's available in your lab or in your hospital. some snare catheters, or thrombin or microspheres. In the room, it's might be important to have mechanical circulatory support devices, such as a balloon pump or an Impella. It's important to have cardiac life support drugs and a defibrillator, and the means to contact other emergency support providers. So the ability to contact the team to intubate the patient. For example, we have an emergency anesthesia team during the day at our hospital that may be available to help us with emergent endotracheal intubations in the cath lab. And then in the hospital, the consideration for whether it's appropriate to have cardiothoracic surgery backup or a perfusion team if extracorporeal membrane oxygenation or ECMO is appropriate. Peripheral vascular specialists may be appropriate to help with peripheral vascular or aortic complications. Echocardiography may be important, and experienced ICU care. So for the rest of this talk about this paper, we're going to discuss several important main areas of complications and the sort of algorithm that's been developed in order to kind of review how to think well about this complication and how to manage it. And then at the end of that, we'll have our discussion of the Q&A. So when we talk about dissection, obviously it's a complication of even not complicated interventions, but dissections are always possible, and it's important to take into consideration balloon size and stent size in order to avoid this. But the good news is that some of the novel techniques and devices that have been developed for CTO operators can help with the management of dissection in just non-CTO interventions, and can help with this management. So the figure that I'm going to show on the next slide is the algorithm that can help with thinking about how to manage dissections, particularly as CTO techniques are very subspecialized and may not be readily available to all interventional cardiologists. It's important to remember that some of the CTO devices are not recommended to be used in the emergency setting. So if these are devices that we don't use on a regular basis, using them in an emergency is not the ideal setting. But if they are used on a regular basis, then their mastery may help in the setting of a complication, even from a non-CTO procedure. I think it's really helpful to go over these algorithms in detail, and I'm generally going to review them starting from the left to the right side. And so we'll follow this review, and then we can comment on it later. So if the patient has a dissection, the first question that we want to ask is there still a wire across this lesion? So if there's a proximal LAD dissection at the edge of the stent and the wire is all the way to the apex, obviously that's a different consideration than if the wire has already been removed, or if it was if the access to the artery was lost and then the dissection was determined. Of course, sometimes dissections are guide dissections, and so there was never a wire in the artery to start with because the procedure is just getting started. And that's important to take into consideration as well. If we think there's a dissection, it's important to avoid antegrade injections, as these can expand the dissections further. But if we know that there's a wire across the dissection, then the next question is the vessel open or closed? If the vessel has no flow, if there is TIMI, zero flow, then the next step would be to dilate with a balloon. So the next step is to basically reestablish flow, and that can often be done initially with a balloon. This may help us to characterize the dissection and extent of it before trying to stent, and may allow us to consider some other techniques. When we consider the stent implantation, it may be appropriate to perform intravascular ultrasound if angiography alone is unable to clarify the extent of this dissection. A cutting balloon may be appropriate if there's large intramural hematoma impinging on the lumen, or it's important to know if it's a distal stent edge that starts the dissection and causing a long dissection in the artery. So this helps determine the extent of stenting that needs to be performed in order to reestablish flow in this patient's artery. If the patient already has flow in the artery and it's not obstructed, then we may proceed directly to assessing the extent of the dissection and then proceeding to stent implantation. If stent implantation is successful, then this completes the PCI. If stent implantation is not successful, then for these patients, we may need to consider other strategies, such as coronary artery bypass grafting. It likely will depend on which vessel is dissected and the extent of the vessel and what the target may look like. It may be conservative management if it's a small branch, or depending on how hemodynamically affected the patient is, mechanical circulatory support or pharmacologic support may be appropriate. How about if wire access has been lost, or if we never had it to start with? It's obviously difficult because attempting to wire this lesion may result in further expanding the dissection or in getting the wire into the dissection plane. So this is where intravascular ultrasound may also be helpful. So using a spring coil wire is often recommended. If wiring is successful and intravascular ultrasound IVUS is able to confirm that the wire is in a luminal position, then this intervention may proceed in the direction of establishing flow. If there is not flow, to dilate with balloon, and if there is a flow, to proceed to stent implantation. If we're not able to access the distal vessel, or intravascular ultrasound shows that it's not the distal vessel, then here are some of the more complex interventional procedures that are learned in the CTO sphere of intervention that may help reestablish flow in the vessel, whether it's antegrade dissection reentry, retrograde wiring if that's an option, or subintimal tracking and reentry. Again, as I mentioned, these are complicated techniques that are important to learn and practice and master for CTO operators, and it's not the right place to use them in the acute setting when somebody has an acute dissection and complication. Then again, I did mention that sometimes getting help from colleagues is an option. And so, you know, if you or me are not familiar with these techniques, but we have a colleague that is, and they're available to help us, then that might allow us to establish flow in the vessel in the true lumen, and then proceed to stent implantation and optimizing the situation for the patient so that they have flow and do not suffer an infarction. Again, if this is not successful, then we need to consider whether it's appropriate to pursue bypass grafting, a conservative management, and then also assessing the clinical situation of the patient to know if they need mechanical support or pharmacologic support. The next major complication that it's really critical to know how to address for all interventional cardiologists, not just CTO operators, is coronary perforation. Main vessel perforations may be immediately life-threatening. And the initial management of perforations should include a simultaneous effort to balloon tamponade the perforation. So in other words, to stop flow into the pericardium outside the vessel, to diagnose this perforation, to treat pericardial tamponade if the patient's becoming unstable, and then to get the support of other operators or cardiac surgeons as appropriate. Even if the perforation is in branch vessels, it may also be appropriate to consider balloon tamponade, branch vessel, distal vessel, or even collateral perforations. And as the tamponade is performed, that often gives us time to consider what the options are depending on where the vessel is and the clinical situation of the patient. And if the perforation is in a side branch that may be small, it may be appropriate to exclude this side branch, either by coiling it, if that is considered appropriate and safe, or by excluding it with a covered stent in the main branch of the vessel. So here is the developed algorithm for managing perforations. So if it's a main vessel perforation, the first question is the patient hemodynamically stable without evidence of tamponade. Of course, heart rate and blood pressure are critical to assess whether there's tamponade, but also using an echocardiogram probe that's placed on the chest to evaluate for effusion around the heart is really critical. If the patient is stable and there's a wire across the area of the perforation, then balloon tamponade can be performed. Balloon tamponade, either using the balloon that was used whether it's a perforation after a stent or a perforation after balloon dilation, re-expanding that balloon at that site will allow time to obtain the correct access and to deal with the perforation. If there's no wire across it, it's appropriate to try to wire the vessel first of all. If that is successful, then proceeding with balloon tamponade will be the optimal strategy to temporize the patient. In fact, balloon tamponade may be the treatment if the patient tolerates longer balloon expansion and are able to maintain hemodynamic support. I'm sorry for this background noise. If the wiring this vessel is not successful, then it's important to think of what the options are. So if it's a severe perforation, can balloon tamponade be performed proximal to the perforation in the vessel? So let's say that the perforation is associated with a dissection and the wire is not able to be transferred to the distal vessel. Is it possible to balloon tamponade the whole vessel proximally to decrease the flow into this perforation area? And if that's not possible, then the questions are, is it appropriate to perform emergency bypass grafting, to coil in the area, or even to enter the subintimal space to seal with a dissection? Again, if you're contemplating this, this is definitely in the realm of more complex CTO kind of interventions. If balloon tamponade is possible, but the perforation is not severe, then the question is appropriate. Is the patient still bleeding? If they're not, then it's appropriate to stop the procedure. At the point that the patient has a perforation, the decision needs to be made to sort of stabilize that situation and then stop rather than to proceed with further interventions. It may be appropriate to consider protamine depending on the situation in that patient. And I think that there are basically two groups that in how how providers think about protamine. Some people consider protamine always after the gear is removed, and the other party really considers protamine to be not an option if the patient has a new stent. So it's important to take into consideration the situation for the patient. Where is the stent? Where is the perforation? How long is the stent? How complex is this lesion? What are the risks for a stent thrombosis from reversing the patient urgently or not? And then, of course, taking into consideration whether there's support needed for the patient, whether there's tamponade or from ischemia. If the perforation is severe and is not treated solely with the balloon tamponade, then the consideration for protamine as well, and then also the covered stent. So just a couple words about the covered stents. There are a number of options that are on the market, although not, like in the US, they're not FDA approved for usual use. They're pretty much available for just emergency use. The Joe stent has been the one that's available for the longest, and it's a very bulky device because it has two layers, the PTFE, compared to the newer papyrus stent that only has one layer and is less bulky. And I only mention this because it's important to know what we have available in our own labs, because if you have them, and I always encourage to have an emergency option, if you have them, you need to know where they are, because they are not stents that we use on a very regular basis, and some of the lab staff may not even know where they're located. But it's also important to know which are available, the sheath size, and what's required for delivery. In the event of the Joe stent, which is quite large and bulky, many times if the guide catheter is 6 French, the patient will need to have a larger guide catheter also introduced in order to deliver this Joe stent. And in this situation, a ping pong stent guide technique is used where an alternative access is obtained. A larger guide is brought up to the aortic root, and in coordination with another operator that is controlling the balloon that's offering the balloon tamponade, then the left main or the RCA can be engaged and a wire passed, and hopefully access to the vessel obtained in order to deliver the stent. The newer world of papyrus stent allows us to not have to do that, because a papyrus stent is able to be delivered through a smaller sheath and guide catheter. And in this situation, the balloon tamponade will be maintained until the equipment is appropriate and available. And then once the papyrus stent is on the table and you're ready to insert it, you deflate the balloon quickly, you remove it on the wire, you insert the papyrus stent and cover the stent, and hopefully that'll be a few seconds worth of time. If it's not necessary to exclude the area of the perforation because it's not bleeding any further, as noticed in this bottom part here, just placing a covered stent may be appropriate. Placing a non-covered stent would be appropriate, whether it's drug-eluting or bare metal stent, depending on what's available and what's appropriate in your specific patient. So in this situation, it's important to move rapidly to treat this perforation in order to try to avoid the patient becoming unstable. Although unfortunately, sometimes distal branch perforations or distal vessel perforations may not be recognized until the patient is hypotensive if that part of the wire is on the screen. It's just a reminder to always maintain good control of the distal wire and know where the position is and visualization of it to prevent that distal wire perforation from happening. But in the event that this may happen and it's and we're not aware of it, sometimes the patient becomes unstable. And if they're unstable, then a very rapid evaluation for whether they have a tamponade is appropriate, giving them intravenous fluids, performing emergent pericardiocentesis, of course, typing cross in the event that they may need blood. And then, of course, depending on the severity of the perforation, they may need to consider emergency surgery. And so that pretty much covers this algorithm for management of vessel perforations. Even after one appreciates that they have good control of the situation, it's important to repeat serial echocardiograms to confirm and assess that there's no hemopericardium and tamponade, particularly if the treatment was balloon tamponade and no stents were placed. It's important to make sure that the patient, in fact, remains stable. Echocardiography with contrast delivered in the IV or in the intracoronary route may also be helpful to assess if the patient has persistent bleeding into the pericardial space. If one notes that there is echocardiography contrast appearing in the pericardial space, that would imply that that's still present. The echocardiography may also help identify a myocardial hematoma. So there's a perforation, but it's not a free-flowing perforation. So there's a hematoma developing within the myocardium because of the perforation, but there's not free-flowing fluid in the pericardial space. So the hemodynamic appearance of the situation is tamponade. It's referred to sometimes as dry tamponade because it's there's an obstruction to the heart expanding and appropriate filling during diastole, but it's not due to effusion in the pericardial space. Cardiac tamponade in patients who have had prior cardiac surgery may be especially challenging, so it's important to keep that in mind if a patient has had prior surgery or there's an intervention on a vein graft. Given that the fact that this area has been accessed, the fluid may be loculated and difficult to drain, but still cause hemodynamic compression of the cardiac structures. This can also help be delineated via the echocardiogram if it shows the effusion and the compression on the heart, or that it's not necessarily free flowing. And at this point, again, reassessing of whether a reversal of heparin anticoagulation is appropriate once the equipment has been removed from the coronary arteries. If the perforation is in the distal vessel or in the collaterals, again, the first question needs to be, is the patient hemodynamically stable without evidence of tamponade? Again, if they're stable, it's appropriate to reassess with echocardiograms to rule out effusion and tamponade. But if there is if the patient is stable and there's the ability to cross the vessel because the wire is still in position, then balloon tamponade is appropriate. Balloon tamponade proximal to the perforation, either across the branch or proximal to the distal vessel perforation. Contrast echocardiography in this situation may help identify any residual bleeding. So if the echocardiography contrast is injected into the coronary with echo imaging, it would be seen in the pericardial space if there is residual perforation. If balloon tamponade is successful, then the procedure is stopped. Consider reversing protamine as mentioned earlier or support as needed. If the balloon tamponade is not successful, because this is in a distal vessel or in a collateral, it's appropriate to consider if there's other ways to prevent further extravasation of blood from this, the branch or the distal vessel. Based on the available devices or materials in your hospital, plus your comfort and the patient situation, it may be appropriate to inject thrombin, to inject fat from the patient themselves or microspheres. It may be appropriate to occlude the branch with a covered stent. Sometimes suction can be performed via microcatheters. Coils may also be appropriate depending on how large that branch is that needs to be occluded. And it may be appropriate to consider antegrade or retrograde occlusion depending on the situation with the patient. And then of course, considering protamine for heparin reversal after the gear is removed. Again, if the patient is unstable, then we need to consider sort of ACLS strategies to stabilize the patient by giving intravenous fluids, performing emergent pericardiocentesis, using a type and cross, transfusion or autotransfusion, and then consider notifying cardiac surgery if emergent cardiac surgery is appropriate. The next complication that we'd like to review is the complication of no reflow. It is imperative when we consider no reflow to exclude other causes that may appear like no reflow, but may be related to the other complications. And a reminder, no reflow is when the capillaries in the heart become obstructed and there's no flow through them. And so then when the contrast is injected in the vessel, the appearance is that the contrast is not moving forward in the vessel and does not wash out. Some other complications that may appear like no reflow include dissection, air embolism, spasm, pseudo-lesion formation, intramural hematoma, or thrombosis. For a true no reflow, the main treatment is various pharmacologic treatments, so we'll discuss shortly. There's not really been any testing of the comparative effectiveness of these different pharmacologic agents, although different hospitals probably have different habits for using adenosine, nipride, nitroprusside, nicardipine, or verapamil as the most common agents used in this setting. The algorithms included in this paper really emphasize excluding flow-limiting epicardial coronary stenosis as the cause because the vasoactive agents really need to be delivered in the distal vessel in order to be effective. So in the event of no reflow, the question is there epicardial obstruction? In this situation, if there is epicardial obstruction, it's important to rule out other etiologies that need to be managed differently. If there's a dissection, obviously, we refer to the algorithm that we discussed first. If there is an air embolism, depending on the severity of it, giving 100% inhaled oxygen to the patient and considering aspiration, or just time for resolution of the air embolus may be appropriate. If there's proximal thrombus in the patient, depending on what happened immediately before this evidence, whether it was right after a stent was deployed, or if there's just a large amount of thrombus in the setting of a STEMI, for example, then it may be appropriate to pursue aspiration and balloon angioplasty to assist in getting flow to the distal vessel. If it does not appear to be that there's epicardial obstruction, it may be the end of an intervention with a lot of thrombus, and the stent was deployed and then the patient develops no reflow. This is most likely due to showering of the thrombus in the distal vessel, obstructing the epicardial outflow. And in this situation, pharmacologic treatment is appropriate. And it's important to know these medications and the doses appropriate so that you know what to use in the emergent situation. So the options, again, as I mentioned earlier, are adenosine, verapamil, nicardipine, epinephrine, nitroprusside, and eptifibatide. And they're given in the distal vessel. And so if access to the vessel is still possible with the wire still in place, it's much easier to take a catheter over the wire, either a microcatheter that unfortunately causes loss of distal wire, so that may need to be considered. And these medications may be injected through this catheter, or there are some catheters such as a twin pass or dual lumen catheters that may have may be able to be delivered over a monorail and then have a long secondary lumen to inject through these if the desire is to not lose wire access. And so that's an option to deliver it via those catheters. If there's resolution of the no reflow, then the case may be completed and the procedure moved on. If the patient continues to have no reflow, the recommendation is to continue with the pharmacologic treatment and redosing the patient. It may be appropriate to give the patient diuretics to improve perfusion pressure if it was noted that they have had a very high LV and diastolic pressure. May consider improving coronary flow with using intra-aortic balloon pump. And of course, if the patient is very hemodynamically unstable, considering circulatory support as appropriate. The next main topic to cover in management of the percutaneous coronary intervention complications is unexpected hemodynamic collapse. The causes during PCI are very diverse. And then following the algorithm really helps the framework to consider the various underlying etiologies of sudden hypotension. That also allows us to exclude spurious causes. We don't want to be treating what we think is hemodynamic collapse, but it's really the catheter dampening or acute aortic insufficiency from catheter prolapse or equipment malfunction. But we need to troubleshoot to ensure that we are truly treating hypotension or hemodynamic collapse. And then once that's confirmed, then we need to obviously address the mechanisms for managing after determining the etiology. So when we have acute drop in blood pressure, the first question is this a real drop in blood pressure? Is the patient truly hypotensive? If the patient is not, then we make an adjustment in whatever we need, whether it means removing the guide catheter slightly from the coronary so it's not dampening, or adjusting the guide catheter so there's no iatrogenic aortic insufficiency, and then we may proceed with the procedure once confirming that the patient's blood pressure is appropriate. If there is an acute drop in blood pressure that is real after this troubleshooting, then the first question is there a pulse? So does the patient continue to have circulation? If there is no circulation, then obviously we need to consider emergent CPR and proceeding with that route. If the patient still has a pulse, then we need to think of the etiology for this hypotension. The etiologies for hypotension really fall into these 5 main categories, and it's really critical to determine the difference between them in order to make sure that the patient's treated appropriately. Is this due to ischemia or infarction? That includes ischemia from guide dampening, thrombosis, dissection, air embolism, or slow or no reflow. Is this due to a tachyarrhythmia or bradyarrhythmia? Is it due to cardiac performance, either acute aortic insufficiency, not necessarily iatrogenic from the catheter, but maybe from injury, acute myocardial regurgitation, or low output? Is this due to a vasodilatory or disruptive etiology due to anaphylaxis, sepsis, or oversedation? Or finally, is this bleeding, perforation, tamponade, or access site bleeding? If it's quickly reversible, then we treat the underlying etiology and hopefully complete the procedure. And after going through something like this, if the etiology is not clearly demonstrated, it's probably not optimal to continue a procedure. It's best to stop if possible. If the etiology is not quickly reversible, then we need to consider appropriate hemodynamic support for the patient and what's appropriate in order to save their life. And then the final main complication that this paper addresses is entramped equipment and the appropriate way to deal with it. Thankfully, this complication is pretty rare, but when it does happen, it's especially challenging when encountered during a PCI. And there's quite a variety of equipment that may be retained in the coronary artery and a number of mechanisms by which to troubleshoot and also to try to work through it. There are oftentimes no straightforward techniques to apply. And so it's, again, a very good area to just have thought through beforehand so that in the event that this happens, you have some ideas already in your mind that you can consider. So the four main substances or devices to consider addressing entrapment of is the wire, entrapment of stents, entrapment of atherectomy burrs, and also finally microcatheters, balloons, or laser tips. In the event of a wire that's entrapped, the question is always, is it still intact? Do we still have access to the distal wire? If we do, but the wire is either jailed behind a stent or is entrapped in the vessel, then we need to think of a number of options that may include just advancing a microcatheter over it as far as possible and then pulling it into it, or similarly, advancing a balloon. Sometimes advancing a guide extension may help and then pull it into the guide extension as a unit. Sometimes we may need to use a snare, and other times a biopsy forceps or atherectomy may be used to help with that. If we still do not have access to the distal end of the wire because it is no longer intact and externalized through the guide, then the question is, does it exit the coronary? If it's still in the coronary, then, but for example, the distal tip separated from the rest of the vessel, then the to just deploy it. Sometimes that means bringing in another balloon into it if if the stent has come off of its original balloon. And as long as there's not going to be a significant size mismatch or a large risk of stent fracture in that setting, it may be appropriate to just proceed with deploying the stent. If the wire is not still through it, then there's a number of different options to consider. First of all, is it able to be snared? Can we use a snare to just try to get the stent out of the vessel? Is it possible to use another wire to try to entangle it so that it's controlled when we pull it out of the vessel? Can we drag it into the guide, or even using a guide extension if we can get a balloon distal to it? Can we stent it into the vessel wall? We may not be able to advance a new balloon through the stent, but if the stent is smaller and we can just inflate a balloon in that area, are we able to just compress it and then re-stent in that area? It's not ideal to have 3 layers of a stent, but it may be much more optimal to have than having a stent that's free floating in a vessel. Sometimes balloon biopsy forceps may be helpful if snares are not. Atherectomy burrs are probably the main reason why many of us feel anxious about using atherectomy or try to avoid it, because when it does happen, it can be a serious complication. If the atherectomy burr is still intact, then there are a number of techniques that can help to try to release it. Gently pushing and pulling the advancer knob, increasing the RPMs, particularly if you're using a rotablator, and sort of pulling back the advancer knob to help release it. Maybe locking it in position and then pulling the whole device. Trying to get a second wire past it to try to modify the lesion with balloon or laser to try to allow the burr to come back. Or cutting the drive shaft and advancing a snare or a guide extension over the shaft right to where the burr is stuck and try to pull it into it. If the device is not intact or externalized through the guide, and there's still a wire through it, it may be able to be dragged out with a snare or using sort of the wire entanglement technique. If there's no wire through it, then the question is, can a wire get past it? If yes, then maybe that's appropriate to try to use a balloon to modify the lesion and remove it. However, if we are unable to pass a wire through the burr that's stuck, then in this situation, it likely needs to be abandoned, and emergent cardiac surgery needs to be considered for this patient. Then the final category of entrapped devices is microcatheters, balloons, and laser tips. Again, the question first is it intact? If it is intact, advancing a second balloon to modify the lesion may be appropriate. Trying to snare it or cutting the shaft and pulling it into a guide extension may be appropriate. Cutting the shaft is in order to be able to advance a guide extension over it. If the device is intact and external, or if the device is no longer intact and externalized, then the question is there a wire through it? Again, yes, that may allow us to drag it in, double, triple wire entanglement, or advancing another wire and balloon to modify the lesion. If the wire is not through it and we are not able to pass a wire through it, it may be appropriate to abandon it if it's a small section, or to consider emergency surgery. And then if we can get a wire through it, then we can consider some of those interventional techniques to try to release it and remove it from the vessel. So to conclude this section of the presentation, PCI is a common invasive procedure with a relatively low complication rate. However, when the complications do occur, operators may be unprepared to manage them if we haven't thought them through. And then uncertainty about complication management can contribute to undertreatment of patients with high complexity. And obviously the goal of our treating patients is to help them and improve their life. And we don't want sort of under treatment to cause more morbidity for them. And then finally, complication management requires preparation, early recognition, broad differential diagnosis, knowledge of effective techniques, team-based communication strategies, and multidisciplinary collaboration. And the authors propose, like I mentioned, that using these algorithms can really help organize our thoughts and prepare us for the times that patients may be unstable and need to be taken care of rapidly. So this concludes this portion of the presentation on complications. I wanted to share with you some additional slides that I had put together about the hemodynamic collapse, because this slideshow did not include that. And so I'm going to share these other slides with you. So I propose, like I mentioned briefly in that algorithm, but we'll cover in a little bit more detail now, that the framework for hypotension assessment should include looking at these three main areas. Is there systemic arterial or vasodilation? Is there hypovolemia, or is there reduction in cardiac output? In the setting of systemic arteriolar vasodilation, there may be vasovagal reaction. So that, and you may be able to predict that's what's going on based on what you know is happening at that time in the procedure. There may be excessive nitrate administration during an intervention, or there may be a vasodilatory response. It's important to remember that iodinated contrast agent reactions may cause a very considerable hypotensive vasodilatory response. And it's, remember, thankfully rare, less than 1% of procedures, but it's an anaphylactoid reaction. It's not really anaphylaxis because it's a degranulation of circulating basophils and tissue mast cells by direct complement activation. And this results in a very significant histamine release. So these patients are in shock with warm extremities due to the systemic vasodilation. 15 to 35% of patients who have had a prior reaction may have it again. And in this situation, then it's important to know that ahead of time and pre-medicate patients with prednisone, diphenhydramine, and or possibly H2 blockers. And of course, it's important to know the emergent treatment, which involves using epinephrine boluses, 10 micrograms every minute until the desired blood pressure response is obtained, large volume boluses, using the Benadryl or diphenhydramine and hydrocortisone in that setting as well. It's important to review patients' medications before procedures because lack of knowledge about phosphodiesterase inhibitor use in patients may cause vasodilation if combined with nitrates, and that may result in severe hypotension if we're unaware of their medications. And then oversedation, as I mentioned, that's why moderate sedation is important with small intravenous doses, monitoring the conscious sedation with monitoring the blood pressure, heart rate, respiratory rate, and O2 saturation, and then having access to the antagonist drugs, naloxone for opiates and flumazenil for benzodiazepines as appropriate based on what the patient has received. Hypotension may be due to acute blood loss. This may be direct access site complications in the femoral. For example, it may be a peripheral vascular complication, not necessarily at the site of access. It may also have aorta or aortic root complications, and they may have internal or GI bleeding. It's really critical to recognize these complications rapidly to treat these patients. Patients having unexplained hypotension that don't respond to fluids may have a retroperitoneal bleed as seen in the CT scan. This may also demonstrate a fall in hematocrits and usually confirmed on CT scanning, but may be predicted based on the situation of the patient. Acute treatment with volume replacement is appropriate. Patients may need surgical treatment or balloon tamponade as appropriate, depending on where the leak is happening. In this situation, you can see that it's a small branch that was leaking, but caused a very significant retroperitoneal bleed. The risks include multiple sticks, a high stick, or injury to the inferior epigastric artery. Some vascular complications such as iliofemoral rupture can cause hypotension, as you can see with this large sheath in this patient's iliac artery. Initially, it may be unrecognized because the bleeding is retroperitoneal or because the sheath may be tamponading the injury, and the bleeding may not start happening until the end of the procedure when the sheath is being removed. The appropriate rapid management may include reinserting the dilator or the sheath, using balloon occlusion techniques in the distal aorta, so knowing your equipment, such as this coda balloon that can that can be used to occlude the distal aorta, or other balloons that may occlude the iliac artery at the site of the bleed. And then ultimate hemostasis may be achieved by a prolonged inflation at the site, either covered stent implantation, or it may require surgical repair. And this is, of course, why prevention is key for access site complications, knowing the anatomy for the femoral procedures. I know many of us have left the femoral access for diagnostic angiography to use radial access, but then our more complex valve procedures and whatnot have brought us back to the groin. So it's really critical to remember the basics of using fluoroscopy to mark the position over the femoral head, using ultrasound to make sure that the access is above the bifurcation, but not too high to result in retroperitoneal bleeding. Of course, as I mentioned, having the toolbox, having the devices available in order to rapidly respond to these bleeding complications is critical, with the balloons to tamponade the flow in the distal aorta or at the access site. And then finally, talking about hypotension, thinking about options that may cause reduced cardiac output, such as ischemia, tamponade, arrhythmia, or acute valvular regurgitation. This patient had acute decompensation due to ischemia from loss of this small RV marginal. And this caused very significant arrhythmia in this patient and hypotension. Hypotension may happen due to coronary perforation and tamponade, as I mentioned earlier, and having a toolbox and a plan for dealing with perforation and tamponade is critical. And then finally, just remembering the other things that we have to use: our pharmacologic management, rapid volume administration, atropine may be appropriate if the patient has bradycardia, considering epinephrine boluses, inotropic agents such as dopamine, dobutamine, or milrinone, or using vasopressors such as norepinephrine or neosynephrine. Obviously, some devices may also be appropriate, such as a pacemaker. If a patient's hypotensive due to inappropriate bradycardia, then pacing them faster than that may be appropriate. And then, of course, knowing our surgical and interventional correction of these problems. A PA catheter may help differentiate hypovolemia versus high output syndrome, such as sepsis or cardiogenic shock. And it may help us anticipate the need for circulatory support. And anticipating this need may allow us to obtain provisional access, put a small placeholder sheath on the other side. At our institution, we have a mechanism for a shock call where we can call the extracorporeal membrane oxygenation team if that's appropriate for the patient. As I mentioned earlier, the team for intubation support may be appropriate as well. So just to conclude this little portion, hypotension in the cath lab may be due to a number of different causes. Careful planning may help identify patients that are high risk for complications ahead of time, but this may not be able to be predicted in everybody. And when the complications occur, early recognition and prompt intervention really allow us to avoid catastrophic outcomes. And the complication management strategies and identification of the devices and available tools is really critical prior to having the patient in an emergent situation. So I think, as we had mentioned earlier, we'll proceed with a small discussion and Q&A for this section, and then we can proceed to the second section, which is shorter than the first.
Yes, Prof. Rania, thank you for your nice, elegant, and informative presentation regarding
this comment. Basically, CTO is the complex of the complex intervention, and so many of the complications are similar. But obviously, the most specific complication noted in CTO is when we're using like retrograde flow and using collaterals, particularly if you're using circumflex collaterals that may be epicardial. So the risk of that is very high, and many operators will do everything to avoid using them because the risk of the perforation complication is much higher. But these, these are also the situations where the intramural hematoma may be the complication. So if you know that that's what you're doing during the procedure, which obviously you do, then if you have a hemodynamic compromise to the patient but don't see an effusion, then intramural hematoma is high on the suggestions of what the complication might be.
Okay. The other question from Dr. Ali, he asked you about how we can
Inject
the fat for perforation, or how we can prepare. Okay.
So this is, I've done it once with a colleague of mine, actually. And I suppose it's a reasonable option if we don't have anything else that's readily available. But just using a larger bore needle and just sucking some fat from one of the, the tissue folds in the patient's abdomen. And this is a very small amount. And then agitating that fat in the syringe, just like you would agitate for, a balloon, for echo to, to look for bubbles across. Yeah. And then a small injection in obviously the microcatheter in the distal vessel. So, what's really critical in these situations is to try to control the situation. So when you inject something, it's not coming backwards. But this is probably, what you find in your kitchen to inject the fat. But thankfully, it's the patient's own fat.
Sometimes we can use even the cloth. We can inject the cloth to seal the
Absolutely.
Yeah.
That's actually another good idea. It might be simpler to do than just fat, but having a little bit of just drawing a little bit of blood into a syringe, letting it clot and injecting the clot can help promote thrombosis in that area. Yeah, that's a very good point that wasn't included in this algorithm.
Thank you, Professor Rania. The other question about the no free
longer term depth, just because they probably are increased risk of thrombosis in their vessel. So thankfully, it's relatively rare. It's not ideal, but it's probably the one retained device that's not going to result in the patient having emergency surgery.
Sure. The other question, if the microcatheter are not available in some cath lab, do you prefer some alternating method to deliver drugs for distal part of the vessel in case of non-reflow?
I mean, basically anything that you have that's a long lumen can work. So you may not be able to get completely distal if you have a guide extension catheter, but that's an option to consider. The other option is, do you have over-the-wire balloons? If you have over-the-wire balloons, the lumen is very small, but you may be able to inject through it. And then also aspiration catheters. If you have a catheter that you're able to use to aspirate thrombus, then that's a long lumen that you may also use in this setting to deliver the drug to the distal part of the vessel.
Okay. The other question from our colleague, Dr. Dia Akram. He thanks for this informative lecture and ask you about in case of catheter-induced dissection, spiral dissection in normal coronary artery, and the patient is stable, should we stent the artery? I think from the algorithm have been some answer. Would you add something else?
Yeah, I think, we sometimes see patients with left main spontaneous coronary artery dissections, not iatrogenic. And the Mayo Clinic experience really is to not treat those dissections in patients who are stable. And by stable, they have flow, they don't have chest pain, they don't have arrhythmia, they don't have shock. The reason for that is because of the intramural hematoma, and trying to stent that lesion can, expand the dissection into the LAD or the circumflex, and really cause obstruction of flow in those vessels. However, I think it's very difficult for an interventional cardiologist who causes an iatrogenic dissection to leave it behind, because you don't know what's going to happen to the patient, 10, 12 hours from then, when they're no longer anticoagulated. So in the event of catheter-induced dissection, if it seems to be contained and there's flow in the arteries, then you look to see if you can just close the entry point. So can you just place a stent in the left main and then exclude the distal stent so that you don't, obstruct the flow in one branch or the other? That may be appropriate. If the patient's really unstable and you just have to get them out of trouble, you might have to do distal left main bifurcation stent into the circle, the LAD. Or this is definitely a situation where emergency cardiac surgery for bypass may be appropriate.
Okay. The next question about which group of patients are more liable to the coronary perforation and predict to have? I think. Okay.
Sorry, I'm sorry to interrupt you. Go for it.
No, it's just I mentioned the high-risk procedure and CTO, and sometimes the perforation from the most common type of perforation is from distal wire. We have to leave the wire distally and forget about the trauma induced by the distal wire. So we have to keep that. Okay, you can. You can.
Yeah, I would add that knowing what wire you have distally is really critical, and sometimes you might need a more hydrophilic wire or a stiffer wire to deliver equipment, but it's appropriate to think about switching that out for a more workhorse wire once you get what you do done, in order to decrease the risk of this happening. Sometimes we're so focused on the proximal vessel that we forget to look at the distal wire, and before we know it, the patient is hypotensive. So that's really important, the distal wire, like you mentioned. Certainly patients with a lot of calcium, these are the patients who are high risk for perforation. And as many of us who do these procedures experience, you know, it might take more time and planning to consider atherectomy on a patient, but you usually, if you think about it and you don't do it, you usually regret it afterwards, because you recognize you have to, you know, you're really fighting the vessel a lot more than if you just did appropriate preparation. So those are situations that might help improve or decrease the chances of perforation. The other comment that I want to make is that vessel sizing and balloon sizing is appropriate. You know, there can be a lot of positive and negative remodeling that helps you overestimate the size of the vessel. And so certainly perforation can happen, you know, if too large of a balloon is used or too large of a stent is used in the vessel. So that's definitely a common complication.
Okay, thank you. The other question may be how to deal with the vessel wall hematoma.
So it really depends on if there's flow in the vessel. This algorithm definitely included the option to use a cutting balloon to try to relieve that hematoma, but I do not have experience with that. In general, if this is a spontaneous dissection, particularly, and there's flow in the vessel, I prefer to let it heal. And I've had many experiences where I've come back to cath a patient who had a spontaneous dissection in the past, and the vessel looks like nothing ever happened to it. So these definitely heal. If the patient has obstruction of flow, then you ask the question is like, where is the obstruction of flow? If we're talking about the proximal LAD, that's obviously a problem. If we're talking about a distal, you know, third OM branch, then you just kind of let that go because you're going to cause more trouble than with trying to fix it. If the patient has a vessel wall hematoma from a dissection and it's in the proximal LAD, then manipulating the vessel as little as possible to decrease the risk of spreading the hematomas is important. And then in these situations, we would take longer stents than we normally would take for the lesion, so that you expand the stent on either side of it and sort of prevent the hematoma from expanding. So it really depends on the clinical situation of the patient, whether it would be addressed or not.
Yeah. We have a few questions for this part of the presentation. Is common iliac artery or external iliac artery or common femoral artery perforation can be managed with balloon tamponade without stenting? What do you think?
So it's interesting. I had a fellow working with me had a high stick recently, and it was just at the top head of the femoral head, but it was going to be for an 8 French balloon pump. So I had him re-stick. That did not, and then there was no bleeding or extravasation at that point. The patient deteriorated further. 5 hours later, we came in to put an impella. And at the end of the impella procedure, after the heparin bolus was given, the patient had extensive hematoma of the abdominal wall. And when we went back and took an angio, it was all from that small branch that had been stuck, or not branch, but that small hole from a needle 5 hours earlier. And we attempted balloon tamponade for quite some time, the patient was stable for quite some time, but then he had a Valsalva, I think, with a bowel movement, and then he had further bleeding and ultimately had to be repaired surgically. I think, especially with these big vessels and perforations that can be life-threatening, most of us are going to have the vascular surgeon consider repairing this vessel unless they're a specific place that's amenable to covered stenting.
Yes. Do we need to do control angio after no reflow after time to assess the flow? This question from Saad Abdul-Razak.
I'm not 100%. I understand what you mean, but you know, it a little bit depends on the situation. No reflow is most common in our experience in STEMI patients, usually because of the volume of thrombus. And none of us like to leave the cath lab in this situation. So we usually, you know, take some more time, give more drugs. Even if we think it's no reflow, I often will consider a glycoprotein 2B3 inhibitor as well, to try to improve flow to the distal vessel. Thankfully, most of them improve with the medications, but every now and then you leave a PDA that's occluded with no flow, and you don't feel good about it, but it's unable to establish flow in the setting of a lot of volume of thrombus.
Okay. The other question from Dr. Amir. Thanks for your nice informative presentation about the use of balloon dissection for dilated coronary artery if there is no reflow. His question is, this technique can increase the dissection?
That's a risk. Although in my experience with the dilated arteries, usually the mechanism of the no flow in the vessel is usually thrombus embolization. So particularly the very large Kawasaki arteries or patients with other problems like that have really dilated arteries, usually it's related to that. So it depends on where the occlusion is and how big the vessel is and the clinical situation of the patient. If they're in shock, you might try to get a wire across. And, I always start with daughtering first. And if you don't know what that means, I just like push the balloon on the wire into position and back, just to see if I can establish flow by disrupting some of that thrombus. And if I do, then I might stop and not consider further balloon dilation. But aneurysms and treating aneurysms is fraught with complications. They have a high risk of recurrence. They have a high risk of further complications, and their 1-year mortality after presenting with an infarct like that is not good. So I think the general thought is to try to establish flow, but to try to do as little as possible. Particularly because in many of these situations, stenting them is not possible because the vessels are too large for the coronary stents that are available.
Thank you, Prof. Rania. And the other question, hope you are not bother you by this question. Okay. Reversal of anticoagulation during perforation, when to take such decision, as we have to use the tamponading balloon or a graft stent, something.
Yeah, so I think, like I said, there are two parties that think about this issue. Some really use it and some really do not. It's tough. I think it's reasonable to consider reversal if you have a patient that is continuing to bleed, you're draining the pericardium, and you're taking them to the operating room. Those are patients that I would probably reverse. I wouldn't reverse a patient if you balloon tamponade and there's no flow. Just like stop the heparin and probably continue close monitoring. In my experience, you might be reassured initially because of no pericardial fluid, and then the patients can develop it later. So it's important to watch them very closely, keep a high index of suspicion if they become hypotensive, even if they didn't have an effusion before, they may develop an effusion. So yeah, it's basically
Yes.
Consider reversing. I think you might take into consideration what you've done to the patient already. If you just implanted 100 millimeters of 2.5 millimeter stent, you probably don't want protamine in that patient. If you put one 4015 stent in the Prox LAD, that might be more tolerable because you're going to have a lot of flow in that vessel, and it's less likely to thrombose. So I think the situation that you're in might also help you decide that.
Okay, Prof. Rania, I have one question.
Yeah.
What is the impact of access site, whether radial or transfemoral, in management of complication? And do we need to shift from one to another for tackle specific complication?
I am a radial operator primarily, but I also am a structural heart, particularly TAVR operator. So I use radial like 95% of the time in my coronary cases, and but have to have a lot of proficiency, obviously, in femoral because of the large bore access that we use. I think a review of the data suggests that there's a number of techniques that we can use to make sure that the femoral access remains safe. That includes, the pre-procedure planning with imaging if you know that you're going to use a large bore, using ultrasound fluoroscopy to get the access, using the smallest sheath appropriate, and then responding to any concerns rapidly. The reasons we're talking about complex interventions, and so obviously many of these patients will end up having their PCI utilizing femoral access. A number of situations include if you need dual injections, so you put a radial and you put a femoral. If you have a small patient and you are doing a left main intervention and need a 8 French or a 7 French, you're probably going to use femoral access for those. So for the complex procedures, part of the procedure planning at our institution includes a vascular imaging. We do a CT scan that helps us. We look at the subclavian axillary access. We also look at the femorals, both to predict where the problems are and also to plan if mechanical support is required if the patient has poor LV function. We really use both and try to help the preparation predict the patient's high risk for complications and to decrease the risk of that happening.
Okay, thank you. The last question from Dr. Mustafa, he asked you about the intracoronary epinephrine and the refractory no reflow phenomenon.
I have never used intracoronary epinephrine. The closest I came to using intracoronary epinephrine was actually a recent case of really extensive anaphylaxis in a patient who had been capped multiple times with no problems. But I've never used intracoronary epinephrine for no reflow personally. I'm curious, does anybody have experience with that?
I don't think so.
Yeah.
Thank you for a very informative, interactive session. And for sake of time, we have to move for the second part of the presentation about the very important subject. And actually, in current time, we have no experience in our country, in Iraq, for hybrid technique. So we would like to hear from you about this subject. Please, the floor is yours
Absolutely.
Again.
Thank you. So the second half of the subject is about hybrid coronary revascularization versus just conventional coronary artery bypass surgery. And this is reviewing some data from a paper that was published in 2020. The background is that basically hybrid coronary revascularization can treat multivessel coronary disease by combining minimally invasive surgical approach to the left anterior descending artery, combining that with percutaneous coronary interventions for non-left anterior descending diseased arteries. So the objective of the study was to compare this hybrid coronary revasc to the conventional approach in medium-term outcomes for their patients. I guess I want to just stop here and just ad lib for a minute. There are maybe quite a number of patients that may not benefit from PCI of the LAD or left main. They might have a good indication for bypass surgery and require lima. They might have a flush occluded osteo LAD or might have a CTO in the prox LAD and surgery might be optimal, but at the same time, they might not be optimal for optimal patients for going on the heart-lung machine, the bypass machine. And like we take care of a lot of patients that are liver transplant candidates or have bad cirrhosis, and the surgeons really dislike putting those patients on pump. So considering this option is a nice tool to be able to treat these patients with a lima, so to give them an arterial graft to their LAD, but that's minimally invasive. It can be performed via a thoracotomy even, or a sternotomy, and then treating the other disease that's non-LAD disease with percutaneous coronary intervention. So the methods for this paper included looking at the data from multivessel disease patients in New York from their cardiac surgery and PCI registries. treated between 2010 and 2016. And they used this to compare the mortality and repeat revascularization rates, comparing hybrid and conventional CABG, and using propensity matching to reduce the selection bias. There was a total of 303 patients that had hybrid intervention and 37,000 patients with conventional CABG, because obviously that's the most common treatment. After the propensity matching, the follow-up time for patients was 3.7 years in the hybrid group and 3.76 years in the CABG group. The basic results of the paper showed that there was no difference between hybrid and conventional CABG in survival at 6 years. The hazard ratio is 1.4 with a non-significant confidence interval, but hybrid revascularization had higher mortality, excluding deaths, during the first year. Conventional CABG patients were more likely to be free from repeat revascularization at 6 months than the hybrid revascularization patients. This is the first graph that they included in their results, and you can see that the solid line is the hybrid revascularization and the dotted line is conventional CABG, conventional surgical bypass. And this basically shows the survival of patients over time up to the 6 years. And you can see here that the number, and it also shows the number of remaining patients, and you can see that the survival pretty much tracks to the 80–85%, and this is what I showed. The difference between these two was not considered statistically significant. So there was no difference in survival at 6 years. After further adjustment of the propensity matched pairs, there was still no significant difference in mortality between the two groups. There were 14 propensity matched patients who underwent PCI in the LAD artery, as well as another artery in a second admission following the minimally invasive CABG. And the hazard ratio for these patients was 4. This is a graph looking at repeat revascularization in patients. And so that, as a reminder, means patients coming back in with a problem that needs to be reevaluated. Again, the solid line is the patient with hybrid revascularization. And this figure shows us really the absence of repeat revascularization. So it's the patients that have no revascularization. So obviously with time, the revascularization increases. It increases to about 60 or 65% of patients that don't have it. So 35% of patients that do in the hybrid versus about 15% of patients that have repeat revascularization in the surgical group. The propensity matched pairs in this second figure show that conventional CABG patients were more likely to be free of repeat revascularization at 6 years, and that was with a hazard ratio of 2. And after further adjustment, there was still a significant difference between these two groups. So a total of 12% of hybrid patients had repeat revascularization in the LAD compared to 5% of the conventional CABG patients. 15% of the hybrid patients underwent subsequent revascularization on either or both of the circumflex and right coronary arteries, resulting in slightly more than half of them having incomplete revascularization after the hybrid. In contrast, only 9% of conventional CABG patients underwent repeat revascularization on those arteries. So when we think about how good and safe this is, we also need to make sure that patients are getting complete revascularization. This shows the hazard ratios of hybrid coronary revascularization compared to the coronary artery bypass graft, and the figure shows on the bottom of the graph here to the right is a tendency towards surgical CABG being better compared to hybrid revascularization being better. And you know, the confidence intervals all cross the line of unity, and so it's really just a trend that we see towards CABG being better, whether we talk about the different age groups, the different genders, or BMI, whether diabetes is present, etc. So in conclusion, hybrid revascularization is rarely performed as an alternative to conventional CABG for patients with coronary artery disease involving the LAD and at least one other major epicardial artery. Hybrid revascularization and conventional CABG have no different 6-year mortality rates, but hybrid revascularization is associated with higher mortality after 1 year and higher rates of subsequent revascularization that are caused by both the need for repeat revascularization in the LAD, where minimally invasive CABG was performed, and in the circumflex and right coronaries where PCI was performed. But the truth of the matter is that this is retrospective data, and a randomized controlled trials are really recommended to confirm these findings. I believe that this is the final slide. So what the study adds is that hybrid coronary revascularization is pretty infrequent. In this New York data, it was less than 1% of the time. There's no difference in mortality between the two groups at out to 6 years. And it was hybrid revasc was associated with a higher rate of subsequent repeat revascularization. So that needs to be taken into consideration. So I'm happy to have a discussion on this topic now. It's actually something that I've been interested in and have performed in the past. And so since you say you're not doing any of those in Iraq, I'm happy to have a more in-depth conversation about this.
Thank you, Prof, for this very interesting subject. Actually, we haven't no more experience in our country, and we are looking for to establish this program within the next few years. I think it's recently not worldwide need more experience, and as you say, did you mention this article and study need more validation and more multi-center randomized trial, because maybe it's depend on a small site, and this is operator dependent. Even the outcome may be related to the experience of that center compared with other center. But this is not well validated study, but I think it's more simple for a specific patient need hybrid surgery to comorbidity or special situation. Out of the box, what's your opinion about this approach? Not specifically about the article per se, but from your experience, from your center, please.
Yeah. You really hit the nail on the head. It's very, very patient specific. So if you have, a younger or a middle-aged person who's a good surgical candidate, it's probably appropriate to proceed with, full CABG. But for the patients that really are going to struggle with the recovery, either from a sternotomy, or they've had multiple sternotomies, or they've have a really calcified porcelain aorta, this might offer an option for the patients to avoid going on the bypass machines, particularly, like I mentioned earlier, if they have liver cirrhosis, or to have a sternotomy. There's a few things that I learned from our experience. Just like anything else, there is a learning curve. The surgeon can find a lima and attach it appropriately to the LAD when they have the sternotomy. But, things look a little bit different when you're looking at the apex of the heart with a thoracotomy. And it's really critical to kind of know ahead of time what the anatomy is, what the course of the LAD is, because I've certainly seen some of the limas end up on a diagonal branch that happens to be quite large. So there's a little bit of, it's funny to say, but there's a little bit of disorientation if this is something that's not done on a regular basis. If it's also done on a beating heart, I have seen some problems with the anastomosis. And when we do these, our practice is to do a completion angiography on the lima to make sure that the lima anastomosis is appropriate. There is some degree of edema at the anastomosis site from the surgery, but at least it should be clear that the touchdown is patent and not twisted in order to have good distal flow in the LAD. And then finally, the PCI portion, these are not the patients that you want to do a complex PCI on. In our situation, we use a hybrid operating room, but it's not in the cath lab. And so It's less optimal to do a procedure that's complex that requires a lot of different devices because you're not in your home environment, so to speak. So the lesions that are perfect for this are like a right coronary artery with a focal type A lesion, because the surgeon cannot sew to the bottom of the heart without moving the heart, and moving the heart requires bypass surgery to decompress the heart. And avoiding that may be an advantage for the patient, and that would be an easy intervention. We've done both PCIs in the setting of the lima and PCIs afterwards. We have the sort of technique, or the strategy we've taken is if the surgeon feels that there's not a lot of oozing and they're able to get good hemostasis in the chest, then we proceed with the intervention. And that's the point that the anesthesiologist gives the patient the Plavix load in the NG tube. If the patient has significant oozing and they're not getting good hemostasis control, we have not been doing it at the same time. And that kind of answers one of the questions in the Q&A about the PCI preceding the CABG. Our surgeons are still very hesitant to operate on patients on dual antiplatelet therapy. And so the general thought of that is not to do it intentionally. It sometimes happens in the event of a patient who, had a STEMI, and so you save their life by opening the right coronary artery, but they still have very significant complex coronary disease and would benefit from a lima on their LAD, and that's done later. But that's not by choice because of the dual antiplatelet issue.
Thank you for a very nice answer for this very important subject. And we have any more question? I think no more question. And I think the message delivered for this two presentation.
Professor, let me just add one thing.
Yes, please.
I believe Medtronic, the company, makes a specific stabilizing device that, and it uses a scope through the thoracotomy incision to allow more easy use of the lima, and then also to secure it on the LAD. So it's worth, if people are interested in doing this and want to do it a lot, it's worth getting the experience and finding out what's available to you, because using these devices can definitely improve the patient's outcomes. And certainly anytime you learn something new, you want to use it frequently in order to get the expertise and improve the skills. And with that, it allows better outcomes for the patients.
Thank you. We hope get more advanced in this technology to raise the standard of care of our patient.
Yeah, and offer things to patients. Yeah. Sorry.
Yeah. Thank you. As far as no more question, and we have a very interesting two presentation from you, and we are very glad to have you over there in our scientific session in Iraq, in Baghdad. And we hope to meet with you in person in any conference, or maybe invite you to visit the Middle East and our base, your base region. Thank you. And we highly appreciate, as I did mention, you tackled the subject with very short notice, and you cover the subject very nicely and widely with this experience. Thank you for your presentation, and thank you for our audience and for our colleagues for their interactive and enforced discussion about this subject. And special thanks for our sponsor, Asino, for organizing this event from
Most
the
welcome,
logistic
Professor.
point of view. Have a good time. Thank you, and see you in next event. Thank you, all of you.
Thank you for having me.
Thank you, Professor Anya.
Thank you.
Thank you very much. Thank you.
Thank you very much. Good night, all.